oral poster and oral selection presentations were generally, I thought, showing modest changes in our practice patterns. Most of what was, I believe, talked about was the shift away from active treatment for Gleason 6 to more surveillance of Gleason 6. That's following the Public Health Task Force guidelines of not doing PSA screening, which I think ASCO did a much better job of reporting on, that it's much more nuanced than what the Public Health Task Force said. Be that as it may, we also saw some interesting data on radiotherapy for early stage disease, some outcomes, and still no practice changing reports for early stage disease. As far as systemic disease is concerned, there was two unfortunately negative trials in prostate cancer. There was the dasatinib trial and the aflibercept trial, showing no advantage for the addition of these new agents to chemotherapy. As far as the other agents, the enzalutamide and the abiraterone, and the third hormone agent, ARN, we saw some expansion of our knowledge base, how it should be used, when it should be used. Certainly the ARN molecule looked quite promising, as did the enzalutamide. But I still think we didn't see at this meeting what I would consider a breakthrough move in prostate cancer. As far as the bladder and testicular, again, much the same, some refining. I think I took away from the meeting a sense that there should be and is a trend towards more use of early chemotherapy after radical cystectomy and even before radical cystectomy. Now, as far as renal cell is concerned, we again had expansion of the knowledge base, but no huge advance. We saw increased knowledge about the tivozanib trial. The TiVo trial was presented as a survival trial. We have the data now. And interestingly, there is no difference in the survival between tivozanib and sorafenib. We saw the COMPARES trial. There is no difference in overall survival between Votrient and sunitinib, both coming in about 26 to 27 months. We saw the update of the BEST trial, no benefit to combination of drugs compared to bevacizumab. In fact, all of those drugs coming in about 22 months overall survival, recognizing that there was a group of those patients who were more adverse. And so the 22 months median overall survival is probably expected because there were worse patients in the group. We saw some very interesting surgical data looking at the role of surgery in what would be called early or indeterminate renal masses, suggesting that we shouldn't be operating on them. It's cheaper to watch, it's probably safer to watch them rather than operating on them. We learned at the poster session a lot about sequencing. There were many papers showing that the physicians are appropriately sequencing therapies, following guidelines, TKI, mTOR, and now beginning to say maybe it could be TKI, mTOR. The new frontier is the third line, maybe the fourth line of therapy. I think next year we are going to see a further refinement of our molecular characterization of renal cell. Everyone is moving more and more to molecular characterization of renal cell, of bladder cancer, and of prostate cancer. Why should we treat some Gleason 6 prostate cancers? Because they're bad cancers. Why should we treat some bladder cancers and not others? Because we have to find the bad cancers. And we will likely see, the first reports of adjuvant therapy for renal cell. We'll likely see either the SUTENT trial or the ASSURE trial come out for adjuvant renal cell. That will be potentially big news if they're positive. If they're negative, back to the drawing board.